Welcome everyone to The Truth About Transition. We are so glad y'all are here, and we're really looking forward to tackling this challenging and important topic of our times together. As folks are joining, I just want to remind you all that we want this to be an interactive experience. So please feel free to share questions, comments, share this video if you find it helpful. We all know that gender ideology is sweeping our nation. There's this idea that you can somehow change your sex, or that your true gender could misalign with your biological sex. And that idea, sadly, is increasingly targeting our children. It's being taught to kids at school, in popular media, even sometimes in the doctor's office. Whether this issue affects you personally or not, this is something we all have to deal with and be able to speak to with winsomeness. And so it's important that we have the facts. And that's why I'm so excited today to be talking about this important topic with a medical expert who can just speak to the truth about this issue. So I'm joined today by Dr. Andre Van Mol. Dr. Van Mol is a board-certified family physician, and he's the co-chair of the American College of Pediatricians Committee on Adolescent Sexuality. He speaks and writes on bioethics and Christian apologetics, and he's experienced in short-term medical missions. He and his wife, Evelyn, have 2 sons and 2 daughters. Thank you so much for joining us, Dr. Van Mol. I'm really excited to have you here.
Thanks for having me.
Well, I mean, this is a big topic, and we're going to go through a lot of issues today, as you know. But I'd love to just start with the basics, since we're talking about sex and gender. Could you just tell our audience, how do we know if someone is male or female? How do we think about that as Christians and scientifically?
Yeah, scientifically, you think that sex is determined at conception. The decision's made. You know, it's not assigned at birth. Every nucleated cell in someone's body, every cell with a nucleus, has your sex stamped right on there. So that's pretty cut and dried as far as that goes. It's identifiable, it's immutable, it cannot be changed. That's in the medical literature. You can't change it. And it's very highly consequential, obviously. You know, medically in particular, or in research, it makes a difference if the patient or subject is male or female. And you can't just ignore that. And sex is, of course, ordered for reproduction. Again, not assigned at birth. And you know, spiritually, theologically, God created us male and female. It was there before the science hammered it out.
Well, I think that's so true. But we unfortunately know that some kids and adults struggle to embrace that. So maybe I as a female would feel like I was born in the wrong body. I should have been male. What is going on there? Can you just explain what that condition is?
Yeah, we're talking about gender dysphoria. It's biologically impossible to be born in the wrong body, but let's put that aside for a second. Gender dysphoria is a strong discomfort with your body's sex. It should be, you know, an infinitesimal part of the population. The DSM-5 says for natal females, it should be 0.003% or less. Natal males, 0.015% or less. And yet, in the past 2 years, we have 3 or 4 surveys and studies saying up to 2% of the kids in America say, yeah, I might be trans. So something changed. It wasn't biology. It wasn't genetics. I can talk a little more maybe about, if you want to think, again, you know, gender dysphoria is a severe discomfort with your body's sex. But you should think of it as a psychosocial neurodevelopmental problem. There's a psychological component, there's going to be a social component, and for a decently large percentage, there's a neurodevelopmental component, by which I mean like autism spectrum disorder.
So you're saying that there could be psychological reasons that someone can feel this. So maybe could you go into a little bit more of each of those areas? Actually, I think our audience would really enjoy hearing what causes gender dysphoria.
We have 40 years of data on that, you know, so we can't pretend like, oh, gee, we don't know what's behind it. Overwhelming probability of mental health problems. So be that, you know, for example, depression, anxiety, bipolar, personality disorders, again, the neurodevelopmental thing of autism spectrum, or adverse childhood events, which of course can be, you know, many, and are recognized in medicine and psychology as being something we're supposed to look for in all kids and all patients. Now, the thing that's going on currently, though, this exponential growth is because, you know, transgender ideology is self-declared. A person is what they say they are when they say they are. And now it's being spread by social and peer contagion. It's everywhere. There's nowhere the kids can hide from it. It's in the media. It's coming at them from their cell phone. Schools are a large source of propagation of this. And, kids want to belong. And so when the idea is out there that, transgenderism is somehow the answer for any discomfort or problem that a kid has, and that transition is the cure-all, well, we've got a problem and a very false diagnosis and false therapy going on.
If anyone in our audience has read Abigail Schreier's work, she wrote Irreversible Damage, you'll be familiar with this social contagion idea, this idea that kids can hear about it, whether it's in school or from other friends and social media, and then sort of self-diagnose and think, oh, that is my problem. Maybe I really was born in the wrong body. But of course, sometimes we'll hear people say on the other side, well, kids are born this way. We know from the time they're 3 years old that they were transgendered. It's just clear. Can you speak to that objection? Because I think that's something that I know I hear all the time, and I think it's really important to understand what's going on there.
You can't be born with a multifactorial adaptation, and that's what this is. A 3-year-old can't tell us what their bedtime is or what their dinner should be. They most certainly can't tell, I was born in the wrong body, but they can be coached into that. They can be fed that idea. Unbeknownst to the parents or the friends, there's all kinds of places to get coached now. And the web, if you start looking up on this subject, will rather easily lead you to the dark web, where people are, of course, waiting to reel you in. It very much spreads like a cult, and many people have come out of it, referred to part of it as the trans cult. And we don't say that to be offensive. It's just kind of the way it is. The American Academy of Pediatricians, in one of their daily bulletins a few years ago, talked about a study out of University of Iowa that said 14-year-old kids cannot reliably, safely cross a busy intersection. Well, I think what I'm about to say next is self-explanatory. So no, a 3-year-old can't tell us that they're living in a biologic impossibility. Something else is going on. Historically, we'd have been looking more for the psychiatric underpinnings, what kind of mental health problems are going on, the adverse childhood events. And of course, kids have very limited capacity to deal with traumas. And if it seems to them that, well, this trauma is happening because I was a girl, then the idea occurs, well, this never happens to boys, so I'm going to be a boy. Or other reasons, say you're a young boy and your example of manhood in the home is just an abysmal person. I don't want to be a man like that. In fact, I have an answer. I'm going to be a girl. Now, that doesn't account for all of it, but there's plenty of examples of people for whom that did account for it, which is why the international standard of care, I think maybe I'm skipping ahead here a little bit, but it seems a teachable moment. The international standard of care is called watchful waiting. That doesn't mean you do nothing. Watchful waiting also incorporates the idea of extensive psychological intervention and support, both for the child and the family. Why for both? Because you're almost certain to find issues in both. And that's why it's been handled that way. But now that's being called transphobic, which is ridiculous.
Tragic, honestly, that the kids aren't getting the help that they need. And that's something I know we're going to talk about a little bit more in this conversation. But I want to throw at you first one other objection that we hear. And this is one I know when you and I talked offline, you said, oh, do we have to talk about this? But I think we do. And that's this idea of these transgender brain scans. And so this is, for those in our audience who are not familiar, sometimes people will say, well, you can just take the brain scan of a child or an adult, and maybe a male brain will show up more female, or a female brain will look like a male brain. And that somehow proves that they're actually the opposite sex. Can you address that?
Deeply flawed, conceptually deeply flawed studies. Again, your sex is marked on every nucleated cell in your body. Neurons have nuclei that'll tell you if the owner is male or female. Now, there may be, male or female differences to brains, but there is no such thing as a male brain, a female brain. So these studies where they're suggesting, that some behavior or trait is associated with some brain morphology are flawed from the start conceptually. And I'm paraphrasing Professor Lawrence Meyer on that. You know, think instead of that neuroplasticity. The brain is muscle. Parts of the brain change as they're used or not used. There's a big difference between neuroplasticity, which is a well-established concept, and this neuroanatomic causation that they're implying. You know, again, it's a flawed concept. Just, you know, flashing a PET scan or an MRI of somebody at some point in time and saying, oh, this trait's more feminine, this trait's more masculine. So what? If we're talking about the 3-year-old again, or we're talking about a 40-year-old, you know, a male who's interested in female things and seems more sensitive, likes to hang around girls more, is a male who likes to do all those things. A female, a little girl who likes to, you know, do the rough and tumble and is a tomboy, is a tomboy. There's nothing more you know what I mean? There's no other consequences that. But after decades of being told, don't be stereotyping, don't stereotype people, it seems the whole transgender ideology is a rigid stereotyping, where if anybody steps out a little bit, oh, you know, maybe you're trans. And that's nonsense. There's many ways to be a little boy. There's many ways to be a little girl. And it doesn't mean you're anything other than a little boy or a little girl. And the same for adults. But again, I was mentioning the social and peer contagion. There's something else called semantic contagion, the spread of words. Once words and phrases appear in a language that weren't there before, people will naturally start to use those as lenses through which to interpret their own experience. But the lenses can be deeply flawed, and people need to know that.
In other words, when we're saying words like transgender or introducing the idea that you could be the opposite sex, people begin to entertain that idea, begin to think that way, including young children.
Yeah. Gender dysphoria is a diagnosis. It's something that you have, not who you are. Transgenderism is an overarching ideology. It's altogether a different thing.
That's exactly right. Another thing that I think often gets thrown in with the transgender debate and with this whole topic is the idea of intersex. People will say intersex people. They're talking about disorders in sexual development. Can you explain what that is and what that encompasses, and then how we can think about that in relation to sex and gender?
Right. Intersex is a colloquialism for disorders of sex development, DSD. That's where you'll see it generally in the medical literature. DSD, again, is a diagnosis. It's a biological malformation. It's something someone has. It's not who they are. Again, biological anomaly. It's not an identity. And it's determined at conception, just like you and I were. And that's science. Life starts at conception. Sex is determined at conception. Regrettably, DSDs are determined at conception. Quite rare, 0.02%. I mean, these people count, you know, we don't exclude them. But the thing is, it's not a third sex. And even the colloquialism is called intersex, not an extra sex. There's 2 sex cells, sperm and egg. There is no third sex. And the presence of biologic anomalies doesn't disprove the human binary of male and female. Now, the thing that intersex conditions, DSDs, have in common, the commonalities, one is the reproductive system develops in a way that's other than we would have expected, and 2, obviously, fertility is affected. Interestingly, people with DSDs rarely identify as trans, and people that identify as trans generally always sounds contradictory, almost always have perfectly normal and functional reproductive systems. So these are 2 separate things, but there's the attempt to lump them together to make numerics look more impressive than they are.
So you're a physician. You say a child comes into your office who has one of these developmental disorders. Are you still able to clearly say, though, that this person is male or female? Or are there ways you can go about that? Because I think that's something I hear often.
This is where all this gets technical. This rarely shows up in the office of a family physician for me, but my colleagues that are pediatric endocrinologists, pediatricians, you know, especially neonatologists, this is going to be their field. So, you know, there's ambiguity of the genitalia. We can't tell. Well, there's a list of things that are done to, you know, rectify it. You know, karyotyping, as we call it, you know, getting a genetic screen to see, okay, what are, the sex chromosomes looking like. There's other screenings that can be done for kids, looking at, again in technicalities, but congenital adrenal hyperplasia is one of the most common. Also, to take the technical talk away, somebody who has no receptors for testosterone. So although everything in the body may look male, they're completely blind to testosterone, in which case that is functionally a female. But again, these kind of anomalies do nothing to disprove that we're male and female, and offer nothing in the column of transgender ideology. These things, we've heard examples, of course, of like an Olympic athlete from Africa who didn't find out about her DSD until she was competing, and it became, an issue. Completely different thing. And we deal with those people as individuals, giving the best medical advice we can, and they make the decisions. And it doesn't have anything to do with transgender ideology, or at least it shouldn't. And I have worked with some groups of intersex people who very much resented being drawn into that argument, and were asking for some help how they could represent themselves, specifically in one African nation where they felt, the trans juggernaut was coming in trying to run the show.
Wow. Well, I really appreciate this distinction that you've drawn between a diagnosis and an ideology. I think that that's really important for those who do have a diagnosis. And I think they can become interrelated, unfortunately, when someone who has a diagnosis gets pulled into the ideology. So now
Yes.
thinking that, that because I have gender dysphoria, that means I must therefore go on to the ideology of being transgender, of identifying as the opposite sex. But for someone who has this diagnosis, what's the long-term outlook for them? What can we expect over the course of time, say for a child who's experiencing gender dysphoria?
The norm with gender dysphoria is desistance. We have decades of literature that just keeps piling up, showing easily 85% of kids with gender dysphoria will outgrow it. It'll be gone by adulthood. And that's if you don't do too much. Obviously, if you affirm it, you are going to sway away from natural desistance to what we call iatrogenically called medically induced persistence. But again, the norm is for it to go away. Now, if you apply the proper international standard of care, extensive psychological evaluation and support for the patient and the family, I think the stats can be even better, considerably better. We have some stats, especially for boys, as high as 98%. So that's pretty great.
That's incredible. And I think that's so important to put out there, again, because we so often we see on television ads this idea that a small child maybe is struggling with gender dysphoria. Maybe this idea has been pushed on them, but for whatever reason, they now want to be the opposite sex. And suddenly that means that they're being pulled all the way into this ideology that we know if they weren't pushed that way in the first place, 98% of these boys would decide ultimately that they're happy being boys. I think that's something that's so important that we need to have out there.
One of the difficulties one of the difficulties I was bringing up is an autism spectrum. And the question would be, well, okay, what does a spectrum kid get pulled into this? Well, spectrum disorder kids have trouble with other than concrete thinking, right? Things that are theoretical, they don't grab on as well. But concrete, that's what they tend to latch onto. And they latch onto the idea, especially if they're coached by the web or others, that now I know why I'm different than all the other kids. It's because I'm trans, which is exactly the wrong answer, but it becomes what they latch onto. It becomes particularly difficult to remove.
It's tragic. Another hard thing that I think we have to talk about when we talk about this issue is the suicide issue. And that's something that obviously we want to take very seriously. If any group of people in particular is having suicidal thoughts or tendencies. But that's something that we kind of hear also as a blackmail card, I think, on our side, to immediately say, this child has to pursue transition or else they're at risk for suicide and suicidal ideation. So can you just address that? Because I really want to make sure we get this right.
Yeah, it's very much used as emotional blackmail, and we have on tape as well as documents certain counselors, therapists, for example, in Canada and the UK, specifically advising their clients, hey, you want to get some attention, threaten suicide. Well, this is awful. Now, again, the suicide card is emotional blackmail. The good studies that do what you're supposed to do, as opposed to the ones that claim 40%, show about a 22% history of suicidal ideation or attempts. I'm kind of glomming those together there, which I realize those are different, but which is substantial, but it's not unparalleled. That's the same stats we have for people with mental health problems, people that are bullied, and for sexual minorities. So not good stats, but it's nothing unique. But part two of this is there is nothing that shows gender affirming therapy reduces suicidality. It's not there. There's junk studies that follow up, 3 months later, 1 year later, 2 years later, which I've had innumerable people that have made the mistake tell me 1 and 2 years isn't enough time to know what you're doing. You're still hopped up on the hormones. You're in the honeymoon period. It takes years to figure out what you've done to yourself. I hear that repeatedly. So the best studies we have, 2011 study out of Sweden, 2019 study again out of Sweden, long-term follow-up. In the case of the 2011 study, showed if you actually follow people who did the whole shebang through sex reassignment surgery, follow them 10 years and more, you see a completed suicide rate 19 times out of the general population. This one that came out in 2019, when it first came out, it said, okay, hormones don't help, but surgery looks like it does. Well, there are a bunch of us that read the study and thought, there are serious problems here. So I led one team that wrote a letter to the editor about it. 7 got published on this one day when the same American Journal of Psychiatry had next to it this little warning bracket that, yeah, we had a lot of people complain. We hired outside consultants, statistical consultants. They largely agreed. We had the authors redo their stats, and lo and behold, surgery did not help the mental health endpoints they were looking for. So we didn't ask for the study to be retracted because we think now it's a particularly excellent study because using all these, fantastic, computerizations and et cetera, we have these 2, studies showing that it just doesn't help. And there's lots of other ones like them, but not necessarily as large gauge. So again, the suicide thing's emotional blackmail, and gender affirming therapy is not proven to reduce that.
Well, it's so tragic, and so many are being pushed to this when, in fact, in the long run, this could actually be more dangerous for them, for their own mental health, and a risk to their lives. That's deeply concerning.
Yeah.
This is something that children and adults are being pushed to. We've been alluding a lot here to transition, and I've been seeing lots of comments from y'all. Welcome to everyone who has been joining us over the last several minutes. I'm here talking with Dr. Andre Van Mal, and he is sharing with us his expertise on this issue about sex and gender. Many of you are asking questions about transgender or about transition. I've seen questions about puberty blockers and how we can care for people who have transitioned, how we can prevent children from going down that road. We are going to start addressing all those questions here as we get into the real meat of this. So, Dr. Van Mal, we keep talking about transition, but can you just lay out, for someone who wanted to pursue that, what would be the series of events that would occur, maybe starting in childhood?
Yeah, there's 4 levels of transition that are commonly spoken about: social transition, puberty blocking, cross-sex hormone, and sex reassignment surgery, AKA gender affirmation or even gender confirmation surgery. And you see how the linguistics is kind of mechanized to get weaponized against us, obviously to not support, gender affirming therapy, which I prefer you think of as transition affirming. Makes it sound like, gee, we're not affirming the person, we're bad people. That's not what it is. So social transition is the easy part. You change your clothing, the way you present yourself, makeup, change your name, that kind of thing. But even in children, social transitioning is associated with persistence instead of natural desistance. And why wouldn't it be? Every responsible adult in this child's life is affirming their delusion. Now, puberty blockade is designed to prevent the kid from entering into puberty. So ideally it starts at Tanner stage 2. But you're interjecting, gonadotropin releasing hormone agonists, powerful hormone, as a blocking agent into an otherwise perfectly healthy kid. So that's going to be a problem. Cross-sex hormones come next, which many of my colleagues refer to as wrong sex hormones. High-dose estrogen in a biologic male, high-dose testosterone in a biologic female. The other side will counter. It's not high dose. It's exactly the dosages recommended for the sex with which they associate. Well, that may be, but it's 20 to 50 times the testosterone a female body would ever see, short of an endocrine tumor of some kind, and vice versa for the male. And then the fourth stage, if they choose to do it, are the sex reassignment, again, AKA gender affirmation surgeries. And those can be in 3 forms. One is contouring, the cosmetics kind of thing to look more like the opposite sex that plastic surgeons, can do with relative ease. Top surgeries, so that'd be things like, mastectomies in girls, losing functional breasts that you can't get back, or for males, inserts. And bottoms surgery would be, affecting the genitals. So orchiectomy, testicle removals in male, that's fairly prominent. Not so many go for the removal of the penis because they've heard the surgeries aren't that great to create a false, vagina appearing appendage. And in women, removal of the ovaries and removal of the uterus. And again, not everybody does those or does all of them. It's actually somewhat of a minority. But for those who do, even if you come to a different way of thinking later, what's gone is gone. And that's one of the reasons we're trying to protect kids from this. We know that these mastectomies are happening down to 13 years of age at Children's Hospital of Los Angeles. We have the documents, and there's even been studies bragging about them doing this. And the bottom surgeries are different things. Those tend to come, they usually try to wait till adulthood, but that's not always the case either. Yeah, I'll let you ask more questions because I'm talking too much on this and technicalities.
Man, well, thank you. Thank you for sharing this. This is, can you all hear me, by the way? Is my sound coming through? Well, I really, really appreciate you sharing this. One thing I would love for you to specifically address is just what the long-term, short and long-term consequences are of each of these. I'm especially interested in the puberty blockers and the cross-sex hormones. I think everyone can imagine, a double mastectomy on a teen girl, just how awful and damaging that is. But something we may be less familiar with is on the drugs and the hormones. So could you just address what kind of long-term consequences can come from that?
Puberty blockers, what they're directly interfering with puberty, which is not a disease state. It's a normal part of development, and it's the part of life where a person most associates with their biologic sex. But those are times of great transition for bone mineral density, the highest increase in your life, brain development, fertility, of course, and that psychological window you have with your peers to go through this together. And when you block those, you've got problems that are going to be long-term. I know it's sold as a pause button, a wait and see. False. That's a myth. It's a sales pitch. Puberty blockers are gateway drugs. They make it almost assured that the child will continue on in transition. We have 4 studies out there that show a 97 to 100% continuance for people put on puberty blockers. So again, it short circuits natural desistance. It selects persistence.
Wow. Well, something that I also would love for you to just address is the way that this affects kids' mental health. We've talked about the long term and the suicide rates, but could you just address how it affects kids' mental health in general, whether it affects their mental health? Because you've mentioned now multiple times that there can be mental health issues associated that are separate from gender dysphoria. So we could be dealing with depression, we could be dealing with anxiety, or maybe not mental health. Maybe a child's dealing with autism, and that they're placing all of that on gender dysphoria. So how should we address that?
Well, chemical castration, which is exactly how puberty blockers work. Chemical castration, surgical mutilation of healthy organs does nothing to address the underlying problems, whatever they are, be they psychological, neurodevelopmental, the adverse childhood events. Those remain to be dealt with. That's true in children, it's true in adults. And they're part of the seeds of regret. When the lights come on, some years later, and it's like, oh, my problems are still here. And oh my gosh, what have I done to myself? So that's when the help really needs to come in from us to help these people, both medically and also for the church. Phenomenal area for ministry, because you can imagine what the anger is like when those lights come on. The lawsuits are forming, and I am going to be very thrilled to help with them. That's how I think this stuff gets turned around, is when the drug companies, the biotech firms, the hospitals, the doctors involved, when they see this isn't a gravy train. Because when you medicalize a kid, you medicalize them for the rest of their life. Their need for those cross-sex hormones never goes away. The complications need treatment. Likewise, if they engage in surgery. So it's a gravy train. You've taken something that should be 0.001%, right? And you've made it 2% so far. That's a 1,000-fold increase in profits. So they need to see this isn't a gravy train. And once those lawsuits start coming, and we can get some other changes in the law, like expanding the window for malpractice litigation, I think this turns around in a big old hurry. We had people like, Professor Paul McHugh, who was head of the psychiatry department at Johns Hopkins and is still there now, out of retirement. He helped shut this down in the first place by bringing simple, scientific studies to their gender clinic. And they found that, all those problems we find in people before their sex reassignment surgery, when you test them, not ask them how they feel, all those problems are still there. And it led to the shutting down of that and almost every other one. I think in 2007, we had one gender clinic in America. Now it's 65, but that number means nothing because Planned Parenthood is in the business of dispensing cross-sex hormones now. So who knows how many? Again, the science alone is going to shut this down with time. But we don't want to wait that long because there's lives in the balance. Kids are getting butchered. Adults are getting butchered, And I think I left out, sorry, but I was answering about the puberty blockers, and I didn't mention at all the risks of cross-sex hormones, because that's what applies to more people, because puberty blockade is only a use, if you're in that range of age. So for cross-sex hormones, which again are wrong sex hormones, testosterone in a biologic female, heart attacks, strokes, breast, uterine cancer, liver dysfunction, high blood pressure, severe acne, and there's other problems. Estrogen in a biologic male in these high doses affects your cholesterol, high risk for blood clots, again, heart attacks, strokes, breast cancer, uterine cancer, weight gain, and insulin resistance, which implies you're going to get impaired glucose tolerance, prediabetes, and even diabetes sooner. The complications are what talk a lot of people out of these things.
Well, and the thing that scares me maybe the most is sterilization. That kids can be signing themselves up essentially for chemical castration at 16 years old, saying this is what I want, not even maybe realizing that that's going to be the result, not being aware.
Yeah, puberty blockers arrest sex development, so the sperm and the egg don't develop. Now, you can remove the puberty blockers and maybe those will kick in a year and a half, but there's no guarantee being full term on puberty blockers is reversible, and the other side makes it sound like it is. But you follow puberty blockers with cross-sex hormones and infertility is assured. You have prevented the development, the maturation of sperm and eggs. And we did some work and we found this on the UC San Francisco Transgender Health, I forgot what they exactly call their clinic, where they warn about these things in somewhat couched language. Some of my teammates and a bunch of lawyers took 2 years to get the consent forms from Children's Hospital LA regarding that NIH national experiment on kids on puberty blockers, and they warn about it too. On the consent form for cross-sex hormones, for puberty blockade, it's there, so they can't pretend that they don't know. And yet, when our team was debating some bills, I think it was 2018, trying to railroad foster kids into a gender affirming therapy, we bring up these kind of things, and we had members of the other teams like, no, we can't deny it. We have the documents now. So yeah, it's just bad news for kids. There's better ways. There's always better ways to address gender dysphoria than chemical castration and surgical mutilation of healthy organs.
Wow, that's again just tragic to hear. You mentioned the serious regret that some people will feel. They come, maybe it's 6 months later, maybe it's 10 years down the road, but at some point, we are hearing from more and more people who have gone down this road and have felt just absolute regret. I was looking the other day on Reddit. There's a big Reddit thread of people who are detransitioning or considering detransitioning. Right. That Reddit thread has over 22,000 members right now. So that just gives you an idea. Given that this is a relatively small part of the population, we have 22,000 people on there who are saying, I've detransitioned or I'm thinking about doing it because there's so much regret there.
Yeah, and consider the bravery of those people, because for decades we have evidence of when you try to express your regret, man, the trans activists come after you, and they're severe about it. You're a traitor to the cause. You make people kill themselves, and worse. So there's courage involved. But now, as you're saying, there's so many of these groups, starting up. They're consolidating. They're getting informed. They're making a common voice. Amicus briefs to circuit and Supreme Court cases written by people who did the transition and have regret or actually detransitioned. So yeah, that's going to be a big help as they come forward.
Well, we're certainly encouraged here at Family Policy Alliance just to see the uprising of people who, whether it's detransitioners or people who are just concerned citizens and watching what is happening to our kids, just the medical, psychological harm that they're being put through when they're being pushed onto this ideology. They're being pushed from a diagnosis to an ideology. What we're seeing happening is that these kids actually are facing serious long-term consequences, but people are pushing back. And so this year, Arkansas became the first. I apologize. This year, Arkansas became the first state to legally protect children from these harms. And so we've just been so encouraged to see that happening. And of course, that's currently working its way through a lawsuit. But we were just really encouraged by our friends there, Family Council, Representative Robin Lundstrom, who made that the first law. But we want to see more states across the country protecting children from these dangerous kind of interventions. So we actually have launched a campaign. It's called the Help Not Harm campaign. And if anyone in our audience is interested, we have the link in the comments and you can click there. And there you'll have the opportunity to actually sign a petition to lawmakers asking them, please protect children, protect them from these dangerous interventions. So you can also get more information about there. I've seen a lot of questions that are answered on that webpage. So if you go to familypolicyalliance.com/helpnotharm, you'll be able to get that information that you need, sign that petition, and then you can spread the word using #HelpNotHarm. So we're just so encouraged by this and hope to see many more of these laws across the country. But we're down to the last few minutes, and I don't want to make it all gloom and doom. I actually want to talk about ways that we can meaningfully help kids who are struggling, because I think it's very clear there are kids who are, for one reason or another, really struggling with this issue. And we've seen some parents commenting here, just asking what can we do? How can my kid get help? And what can I as a parent do? So I'd love for you to just address that.
Yeah, some 3 great websites or web resources. One is the Parents Resource Guide, which hopefully that's going to be flashing up here in the column shortly. ACPEDS, the American College of Pediatricians, they have an extensive section on this, as well as how to get a counselor. Walt Heyer's Sex Change Regret site. He's somebody who fully transitioned and then detransitioned and has been helping people with this problem for decades now. Those are 3 great sites. For parents themselves, how you approach it depends, on the age of your kid. Of course, you act one way with smaller kids, you reason other ways with an older child. Maintain the courage of your convictions. Don't cave to zeitgeist, and the pressure to do it will be extraordinary. Be prepared, to block websites, block TV shows, find out what your kids are up to, ask questions about, what's happening in the school, because schools are a primary means of this being propagated now. Walt Heyer recommends that you ask the right questions and be a listening sponge. Be prepared to have 5, 10 conversations with somebody on this. Don't rush it. And, make sure you listen really well to their answers, because otherwise they're kind of trained to shut you off really quick as soon as they see what they view as non-affirmation. And develop a trusted network of resources. Your trust, not what the gender clinic says. And that's becoming easier and easier to do now. Just take a look at these resources we talked about. They're going to be helpful. You can look up stuff I wrote for the Christian Medical and Dental Association, cmda.org, or also Public Discourse. But focus on those top 3. I said first, the Parents Resource Guides, ACP's website, and Walt Heyer's Sex Change Regret. It'll give you a great start and beyond.
Those are all really helpful resources, and I've seen our team is putting those in the comments. So if you're a parent who has a child struggling with this, or you just want to protect your child ahead of time because you're concerned they could be facing this at school or on social media. Social media is a huge vehicle for this. So it's good to be prepared as a parent. I'll just share one other resource that Family Policy Alliance has that may be helpful to parents as well. It's our Back to School Guide for Parents. So if you have a child, especially who's in public school, this guide is going to walk you through every room, classroom, counselor's office, locker room, every room of the school, and tell you here's what could be happening in your child's school. Here are the red flags to watch for. Here's how you actually take action if something something bad is happening in your child's school, something that maybe could be pushing them toward this ideology or is another outflow of this ideology. So we just encourage you to download that guide. It's totally free, but we just want that to be a resource for parents. Dr. Van Mol, with just the last couple of minutes here, I would just love for you to share maybe speak directly to the parents and people who have loved ones who are struggling with this, because it is, as you said, the diagnosis is very real. It's been turned tragically into an ideology that is just destroying people's lives. It's destroying them physically. It's destroying them emotionally and psychologically. But nonetheless, there are people who have a real diagnosis. And so for those who are facing that, could you just share a word of encouragement to them?
Yeah, doing the right thing doesn't mean you're not going to get pushed back for it. Be loving, be compassionate. We know how to do that, but recognize that, love is not codependency. There's a corrective element to love, not, again, not to harp on people and stuff, but, compassion comes with truth. Speak to people, let them know you love them just like you accept them just as they are. But again, ask those right questions. How did you decide that you weren't comfortable being who you are? When did you decide transition was the answer for you? How did you come about this? And listen, because that's going to give you cues on what you need to address. But the person's got to want help is the thing. I mean, take the example in the Gospels of, Jesus by the pool. The first question he asks the guy there is, do you want to be made well? We know as doctors, if somebody doesn't want it, you can't really force it on them. But you can be available. You can be a source of good information. You can be a source of compassion and acceptance, even when we desperately disagree with people and think they're doing great harm. Be encouraged. Again, surround yourself with a network of good information and good people, and realize that people come out of this. There's hope, and we are supposed to be ambassadors of hope. So let's make sure we're living up to our part of it, even if the other side makes life very difficult for us.
Amen to that. I saw someone in the comments a few minutes ago had posted that kids are being hurt by this, and we can't wait to take a stand. Right. Every day that we wait to take a stand, another child is going into a clinic. They're being encouraged to get on puberty blockers, cross-sex hormones. They're facing chemical castration, a lifetime of hurt and regret. When we know that, as you said earlier, in the case of boys, 98% of them are going to end up saying that they don't. they don't identify as female, and very high rates for girls as well. And yet they're being pushed to just these tragic interventions. So I just want to encourage our audience. Thank you all so much for joining, and thank you, Dr. Van Mol, for being here. I want to just leave you all with an encouragement that now is the time to take a stand. And if you are passionate about this topic and want to take a stand, again, sign our petition. It's the Help Not Harm petition. We have the link in the comments. Take a look at the resources that Dr. Van Mol mentioned. So those are also in the comments, and we'll post them in the caption when we repost this video later. And then make sure that you're spreading the word with friends. There's a lot of information here today. If you registered for this, you'll actually get a recording of this video. So you can come back and watch it and say, wait a second, how did Dr. Van Mol answer that question again? I want to get those facts. So that when your friends and family ask you these questions, you can answer them and you can be ready to be winsome and loving and really make a difference in the lives of kids who are hurting. Thanks so much, everyone, and have a great day.
Thanks.
Well, that's a wrap on the Help Not Harm Summit. Thank you all for coming and engaging today. If you want more information and opportunities to engage, check out our website at familypolicyalliance.com. Be sure to follow Family Policy Alliance and keep up with the latest content. You'll find us on Facebook, Twitter, Instagram, and YouTube. And of course, be sure to check out the many great resources that our speaker shared today. And one last reminder, if you haven't already, please sign our Help Not Harm petition to protect children. I'm Craig DeRoche. It's been delightful to be with you today, and I'll see you next time. Thanks for joining.